time. Okay, so here we are. I really might be getting used to this course right now because I have absolutely nothing to say before we get going. Nothing came to my mind. I had a good day. Weather is still kind of lousy here in Chicago, and we might as well get right into it. Good place to go is to the PowerPoint. But before we do that, I have to do my audio-visual test, and you know what part 1 is. Part 1 is, can you all hear me? And I'm seeing a bunch of yeses. Good. Part 2 is, please tell me what you see on my screen, which is the same as your screen. Great, flowers. So everybody is cooking, and now we're ready to go. Now I can click open my PowerPoint. And if you remember, we spent the vast majority of time in the last session talking about atherosclerosis, dissecting it thoroughly. We are almost done with that particular aspect of it. There's a few more things. I believe we made it all the way down to PowerPoint number 43 out of 119. And yeah, that's where we ended off with our saga told many different ways from many different angles. And the final way we're going to look at it, very much repetitive, is once again remembering the sequence of events and the progression of events, just like we did with inflammation and coagulation. One thing follows another. And of course, number 1 here in our saga, according to the pathogenesis section of Robbins, is the concept of chronic endothelial injury. Here's our endothelium. It's the innermost portion of the intima. The thickest portion of the artery is the media, and then there's a little connective tissue, the adventitia. Well, what are some of the things that could injure the endothelium? How about hyperlipidemia, for one? We saw the role of hypertension. We saw the role of cigarette smoke. We saw the role of homocysteine. We adhered to the general Virchowian principles of hemodynamic changes. We know toxins can do it. We know viruses can do it. We know chlamydia can do it. And we know that you can have an autoimmune phenomenon as well in the absence of external antigens. These are all the things that could injure it. The response to injury, and the first thing we see under the microscope, is monocytes adhering to the endothelium and diapedicing or oozing, or besides adhering, emigrating below that endothelial layer into the deeper layers of the intima. And that's the very first thing we see. A collection of these is called a fatty streak once they are in the subendothelial intima. We quickly see disruption of the internal elastic lamina, the migration of smooth muscle cells, and basically a progression and accumulation of more and more and more cholesterol-like fats. So there's your fatty streak. And by the way, if you can actually palpate a bump under that fatty streak with your finger at an autopsy, you can probably call it a plaque rather than a streak. But sometimes it's a pretty fine line of differentiation. You now have your inflammatory reaction in the intima, which can be so big and so thick that you really can't tell anymore any difference between the media and the intima. And often this inflammatory reaction, consisting of lymphocytes and smooth muscle cells and foamy macrophages and maybe calcium and maybe fibrosis and maybe cholesterol clefts, can be the majority of the thickness of the wall of the actual artery. Finally, step number 5 is more of the same things we saw from step number 4. More collagen, more lipid, more lymphocytic reaction, and of course with chronicity, not only do you get more collagen and more scarring, but very much likely to get calcium as well. Usually when you cut through an atherosclerotic artery that's heavily plaqued, you can hear the the scalpel blade crunch through the plaque. So you could diagnose atherosclerosis even if you were blind, as long as you had a scalpel in your hand. So once again, here are your 4 stars of this entire saga, with the biggest one and the earliest one being endothelial injury, then the subendothelial inflammation, the accumulation of lipids, and the role of smooth muscle cells. Remember, once again, the SMCs are not just there to contract like they are in most other places of the body. They're also there to lay down ground substance as well, in which all of the lipid and inflammatory debris has accumulated. Okay, couple of final points is that, you know, in pathology from day one, I told you that there's basically, from the point of view of pathologists, and especially anatomic pathologists, we like to think of diseases as either degenerative, inflammatory, or neoplastic. And if you remember, all of the chapters of systemic pathology are basically organized that way. And of course, when we give you examples of degenerative diseases, you know, we say things like arthritis, you know, degenerative arthritis. We also put atherosclerosis at the top of the list as the mother of all degenerative diseases. But the interesting thing about this #1 disease on planet Earth is that there are evidence for significant interactions with the other 2 types of disease. For example, when you look at the cells in the plaque and you do genetic studies, they are oligoclonal. They are all from the same clone. Now, does that mean you can call it a neoplasm? Well, I don't think so, because most people would not call atherosclerosis a neoplastic disease by any stretch of the imagination. But keep that in mind. This thing that we have also called degenerative now may have some role in being neoplastic as well. And remember, we told you that a couple of the common organisms, especially chlamydia and CMV, are very, very popular for injuring endothelium. And of course, there's an inflammatory reaction underneath that endothelium coat. So can we call atherosclerosis maybe an inflammatory disease or an infectious disease even, based on their strong link to these organisms, which are very, very often present at some point in time in the human body, especially CMV? Well, maybe we can. But I just wanted to point out this slide to show you that atherosclerosis is the mother of all diseases. And the mother of all diseases wouldn't be appropriately termed unless we could show links to all types of diseases. So this degenerative disease is also linked in certain ways to neoplasm, as well as inflammatory or infectious diseases. Prevention principles, well, we've mentioned it. Let's give the general principles. I think you have to know what your major and minor risk factors are, because you have to know which principles are to be attacked or prevented. And you all know that the 4 major risk factors are all either preventable or treatable. You know, the hypertension, the cigarette smoking, the diabetes, the hyperlipidemia. And you should know both primary as secondary principles, understanding that atherosclerosis begins in childhood. So if you're going to have significant prevention, you have to start it in childhood, not after the fatty streaks have turned into plaques and maybe even more well into the adult life. And remember, the risk factors that are present in children predict the adult profile. So if you have a high risk adult for heart disease, for thrombosis, for stroke, remember those risk factors were in him way, way, way before he or she actually got the plaque. And of course, we remember the protective role of estrogens for women, some ethnic differences, but the big thing is diet and the so-called level of, quotes, development of the society. You know, I wouldn't be fair to you if I didn't bring up the question that, is always brought up on every discussion as a final point, is I don't think I've ever given this talk in real life and somebody didn't come up afterwards, usually with a vested interest in the question, and say, can atherosclerosis be reversed? Well, if you read all of the major sources, including Yahoo Answers, the answer is no. Okay? Like, can cancer be reversed? Well, that's maybe debatable. Atherosclerosis cannot be reversed. Okay? It could be slowed down. It could be treated mechanically. It could be at the point where it's perhaps arrested by appropriate therapies, but it generally does not go away. And now that we can measure, the amount of lumen that's open, and perhaps even quantitate the calcium in coronary arteries, I don't think you're going to find too many examples of the stuff going away. Now, there's no doubt that about once every year, or every 6 months, you're going to read some study from a non-reputable journal, or perhaps an internet spam or scam ad that will give you profound information that this could be done. But I want to tell you, the answer is no. So when you hear every now and then, about every 6 months, of an amazing breakthrough, it's either by some lunatic doctor that wants to be famous and he published it in an irreputable journal, or more likely somebody that wants to make a lot of money from poor, sick, atherosclerotic people. So you don't go from here to here. The other direction, of course, everybody goes from right to left, but nobody goes from left to right. We're done with the big discussion on atherosclerosis, which is the majority of the meat of this chapter. We're going to talk about a few other topics, not quite as lengthy. We're going to talk about hypertension. Remember, I'll be talking about this in the chapter on heart as well, under hypertensive heart diseases. We'll talk about aneurysms. We've already told you that the majority of them are caused by atherosclerosis, but not all of them. So we'll give a little bit on the principles and sequelae of aneurysms. Then we'll talk about the vasculitides, or the large family of inflammations of blood vessels, particularly arteries. And because we do not have a lot of specific organisms, infectious organisms, which cause that inflammation, you would imagine the vast majority of them are in this categorization of autoimmune. We'll say a little bit about veins, because the chapter is on blood vessels and we've been spending all our time on arteries, and then get into a few principles of the neoplasms of blood vessels. Blood vessels are connective tissue, so a malignancy of a neoplasm might have the word sarcoma after it, although some of them don't. Hypertension, very simple. No reason to spend a lot of time defining it. There have been a lot of variations of this definition, but let's keep it very, very simple. If you define hypertension as almost all, or 95% essential, or I guess you could call it primary, but nobody calls it primary. They all call it essential hypertension, which means idiopathic. Nobody knows what causes it. And in about 5% of the cases, we know what causes it. It's related to renal and endocrine diseases, so we call that secondary. And just about every type of endocrine disease known to man is likely to produce some type of hypertension. But the definition of hypertension, the kind that you'll be treating 95% of the time, is essential, primary, idiopathic. And here's the definition. Very simple. Any sustained systolic blood pressure over 140, or any sustained diastolic pressure over 90 is hypertension. Not too long ago, everybody felt that the sustained diastolic was much, much more important to treat than, technically fluctuations in the systolic. I'm not too sure if they think that way anymore. Another thing that used to be very popular is to give an elderly person a little bit of leeway. So I've even heard it said that if you add if you add your patient's age to 100, that would be a normal systolic. Nobody really believes it anymore. Let's make it very simple. Any blood pressure sustained 140/90 is hypertension, and leave it right there. The primary essential hypertensions are idiopathic. They're all tied in to the renin-angiotensin-aldosterone axis. And the secondary ones are either renal or endocrine or cardiovascular, even some miscellaneous anatomic things. But here, remember this. Any situation of the kidney, whether it's ischemia on the base of stenosis or fibromuscular dysplasia, or a vasculitis causing ischemia, or in general, chronic renal diseases, even the acute glomerulonephritis. This is almost all type of renal diseases are likely to produce a hypertension rather than a hypotension because of the increased renin. And look at, could a renin-producing tumor of the kidney or even of other places cause hypertension? Of course it could. So renal is a big factor. One that's almost as big as endocrine. If you look at this list here, whether you're talking about adrenal cortical hormones, whether they're aldosterone or cortisol, or exogenous hormones like them, estrogens, glucocorticoids, sympathomimetics, and foods even containing tyramine, MAO inhibitors, these are all considered endocrine causes. And look at, not only will hypothyroidism be associated with hypertension, but even hyperthyroidism, probably the two most common types of endocrine disorders. A tumor producing epinephrine, like pheochromocytoma, even acromegaly, that's growth hormone. The pregnancy increased hormones. I don't know if there's anything on this list that's a hormone, that cannot be associated with hypertension. Anatomically speaking, if your aorta was coarcted or severely constricted, wouldn't it be logical to think that the pressure proximal to that would be increased? Of course it was. What about an inflammation of an artery in which the artery wall is significantly thickened and narrowed by the infiltration of inflammatory cells of various types, or any other vasculitis? Anatomically speaking, don't you think that might be associated with hypertension? Especially if there's a lot of arteries or big arteries? Of course. And remember, increased vascular volume is probably not only a cause of hypertension, but it may even be an effect of it because of the increased pressure. Now remember, the more cardiac output you have, the higher your blood pressure is. What about in the aorta that's rigid and non-compliant and has disrupted or inflamed or fibrotic elastic fibers secondary to a wide variety of neurologic situations? People with head trauma and increased intracranial pressure are very often very hypertensive. We all know it's associated with sleep apnea. Acute stress can raise your blood pressure, even the acute stress of surgery. So these are all reasons. I'm going to make myself grammatically correct and keep my letters small. So hypertension, very simple. Blood pressure is directly caused by cardiac output. The more blood your heart is putting out, the more pressure there'll be. And peripheral resistance. So the more resistance you have in your peripheral vessels, chiefly at the arterial level, the higher your blood pressure will be. That's a simple formula. And, you know, we don't like to keep things simple here all the time, so let's make this a little more interesting. There's your blood pressure. Cardiac output is determined by blood volume. You know, the more sodium retention there is, the more blood volume you have. You know, the mineral corticoids are very good at increasing blood volume. That little hormone secreted by your atrium, the atriopeptin, does the same thing. You know that cardiac output is the result of both heart rate as well as stroke volume or contractility, even though stroke volume, of course, is not exactly the same as contractility. A high ejection fraction, okay? These are all things which will raise blood pressure from the cardiac output part of the equation. Now, let's look at the peripheral resistance. And the rule is, logically speaking, the more resistance you have to that flow of cardiac output, the greater your pressure will be. So, things that constrict your arteries, particularly smaller arterioles, because the resistance to cardiac output in your body is chiefly at the arterial level. Remember, angiotensin II does it after it's been converted from angiotensin I by the angiotensin converting enzyme. Catecholamines do it. And remember, even the mediators of inflammation like thromboxane, leukotrienes, we mentioned endothelin as being from the endothelial cells. Endothelin is a powerful vasoconstrictor. And what if you want to lower that resistance and therefore lower blood pressure? Well, remember, nitric oxide is a great dilator. Many of the kinins are, and some of the prostaglandins. So it's a controlled system here. The neural factors, well, remember, the alpha adrenergic receptors constrict blood vessels, and the beta adrenergic dilate them. So this factor and all of these factors, all the constricting factors, whether they're neural or humerals, they're going to result in increased peripheral resistance. On the other side are your dilators, which will decrease it and therefore technically lower blood pressure. There you go. Remember, even things like pH has a significant effect on blood vessel contractility or dilatation. Hypoxia, the same thing. Remember the concept of shock. So this is one way of looking at it, and the chart could have been a hell of a lot more complicated, but to me, I really like this one. Now, when you are practicing medicine and a drug company guy comes up to you and he says, hey, come on for our free dinner at the Marriott Hotel, you get a steak or a prime rib, you know, you're going to sit down, and 9 times out of 10, you're going to hear some guy talking about RAS, okay? Because this is the basis of almost all antihypertensive therapy, realizing that it is all, or pretty much all, essential. And the primary control is at the level of the kidney, which secretes renin from the juxtaglomerular apparatus. Remember those little cells in histology? Well, under the influence of decreased flow or hypoperfusion, your renin is increased. Those little granules right there in, from the juxtaglomerular apparatus. And that enzyme renin then cleaves a peptide called angiotensin, OGen, and converts it to angiotensin I. Well, so far everything is going nice, but angiotensin I by itself doesn't do very much. So chiefly in the lung, angiotensin I is then converted to angiotensin II by appropriately termed angiotensin converting enzyme, or ACE. That's why not only almost all of the slick blood pressure pharmacology or antihypertensive pharmacology now are based on ACE or ACE inhibitors. Not only are they big, but they're getting bigger. and that little enzyme is found chiefly in lung capillaries. Now, once you got that angiotensin 1 converted to angiotensin 2, you got your active product. And angiotensin 2 does a whole wide variety of things. But keep things simple. The reason why it's called RAAS is we're going from renin to angiotensin, and angiotensin 1 converted by the ACE enzyme to angiotensin 2 then does a bunch of things, but the main thing that it does, it causes release of aldosterone. Okay, and the net effect of aldosterone is to reabsorb sodium. And when you reabsorb sodium, you reabsorb water, and therefore you got to increase blood volume and all. There you go, increase blood pressure as well. Here's another way of looking at it. This is the same thing we just said. You got decreased perfusion in the juxtaglomerular apparatus, so your kidney releases renin. In the liver, then, which makes angiotensinogen, you're converting that, cleaving it to angiotensin 1. Then in the lung, you have the enzyme called ACE, angiotensin converting enzyme, puts it into angiotensin 2. We told you the main thing that angiotensin 2 does is act on the produce aldosterone, release aldosterone to produce sodium retention by the kidney. But look, it does a whole bunch of other things too. I've made a little list down here. Angiotensin 2 also increases sympathetic activity and results in the constriction of vascular smooth muscle. We all know that it does tubular reabsorption. It would look to me from this list that it does it directly as well as through aldosterone. I'm not too sure if that really matters, because the end result is that sodium is reabsorbed, potassium goes the other way, and now you have increased water retention. It also has a direct effect on arteriolar vasoconstriction and ADH secretion as well, if that's not enough. It also works on ADH, also with the end result is to reabsorb water. So these are like 5 different ways that angiotensinogen 2, after being converted in the lung from angiotensinogen 1, which was produced from angiotensinogen in the liver by renin from a hypoperfused kidney. And that's the whole RAAS system. And chances are, when you go to those little dinners, you're going to get a nice wine and a nice steak, and they're going to kind of assume you already know this. Of course, it would be nice if they reviewed it. In some way or another they do, but they always have their little drug company logo at the bottom like they invented it. Actually, the guys that did discover this got a well-deserved Nobel Prize. Here's another chart dividing the font into red and blue. And the red items in this whole axis here, the RAS axis, are the things which are genetic and they're not under your control. And the blue ones are the acquired things which can be controlled in one way or another. Remember, when we talked about kidney, we said that fibromuscular dysplasia was basically inherited a genetic situation. Young women, pipe-like thinned lumen renal arteries. That's genetic. You can have renal artery stenosis from atherosclerosis. You can have a tumor which produces renin. Okay. What about angiotensinogen? Well, we know that oral contraceptives have an effect on it. And we all know that there are angiotensinogen variants as well, which are genetically determined, and that would have an effect on angiotensinogen, and the ease of which it may or may not be converted to angiotensin 1 by renin. Now, angiotensin 2 works on aldosterone to pour out mineralocorticoids, remember, from the zona glomerulosa of the adrenal cortex. Now, some of the enzymes at that level, like 11-beta hydroxylase and 17-alpha hydroxylase, they can be deficient, or as an acquired condition, you can have a tumor of the adrenal cortex, an aldosteronoma. Of course, when you look at it under the microscope, you don't know it's secreting aldosterone. You just see a big yellow ball, filled with cholesterol substances, and they can produce an increased amount of mineralocorticoids as well. Now, at the mineralocorticoid receptor level, you can have a couple of genetic diseases, like an 11-beta HSD, like we saw up here. But there can also be glucocorticoid resistance as well. Last but not least, licorice. There's something in licorice which interferes with mineralocorticoid receptor activity. You can have hypertension on the basis of that. And a little question mark after Cushing's syndrome, because Cushing's syndrome technically is increased glucocorticoids rather than mineralocorticoids. But there is some overlap. And remember, increases of glucocorticoids are related to hypertension, but not as strongly as increased mineralocorticoids, like aldosterone. Okay. You should at least, well, I don't know. Let's just say at the very bottom, these are a couple things you'll never see in your life, except for maybe on the boards. I think you should know that there's a couple of syndromes, like Gitelman syndrome, Liddle, L-I-D-D-L-E, that are also genetic, okay, in which it's a mutation producing problems with either the cotransporter or a subunit of ENaC, either the beta or gamma or alpha or beta, which are genetic conditions as well. Nevertheless, this is how you can divide this axis here into conditions which are either genetic or acquired conditions which affect this axis. And of course, once again, the basis of almost all modern antihypertensive therapy in general would be something that has an effect on this axis as a general process somewhere along the line to slow it down. This is possibly taken from the lab, and I don't know if we'll be getting there too soon, but I want you to remember that hypertension, even though it's essential 95% of the time, you can usually see a rather predictable changes in the kidneys. We talked about this before. I'll mention it again. The end result is when you see small blood vessels in the kidney, call them arterioles, okay? In most hypertension, you'll often see a lot of sclerotic arterioles, and this condition is called nephrosclerosis. And look how the sclerosis in these small blood vessels, or if you would like to call these arteriolosclerosis, that's very good. Look how stable it is. It looks almost like boring, stable collagen or something that's pink, and makes this vessel looks more sclerotic than it should be. That's called benign hypertension. Okay? Could it be a cause of more hypertension? Yes. Could it be an effect of hypertension? Yes. Now, when that wall is layered out like skin on an onion, or perhaps necrotic, so it looks a little bit like granular fibrin, those are two things in which the wall is no longer looking, kind of quiet. These are more active. when the walls are showing more active destruction, that's frequently associated with malignant hypertension. And it doesn't mean that the cells are malignant, it means clinically it's malignant, because malignant hypertension is very often sustained systolics of more than 200. It has a very, very high mortality and has a very, very high relationship to stroke. And people with malignant hypertension very often live a lot shorter than patients with malignant tumors. So, end result, when you see onion skinning around an arteriole, or fibrinoid necrosis, which I don't think we see here too well, but it would look very much like granular pink hyaline substance, very much looking like fibrin, but it's not. That's why it's called fibrinoid. These are things which are features of malignant hypertension. Okay? Does it look like you've seen this chart somewhere before? Like maybe with atherosclerosis? What are some of the environmental controllable factors for hypertension? We know that genetics are uncontrollable, but what about the environmental? Can they be controlled? Well, there's a relationship to stress. You know, somebody that's stressed out is often talked about as having their blood pressure up, and very often it is. Furthermore, a hypertension in itself can stress you out emotionally. Obesity is related to hypertension. Lose 20 pounds, you'll lower your blood pressure. Smoking, okay? Not only damaging the endothelium, not only promoting atherosclerosis, but also raising the blood pressure, even before those things may be happening from a physiologic perspective. Nicotine. Physical activity raises blood pressure acutely, but in the long run, a good program of exercise lowers blood pressure. Isn't that kind of ironic? And of course, the big one, and no matter what you put your patients on when they come in with their essential hypertension, whatever in vogue when you're in practice, remember, you're always going to tell them to limit their sodium, their salt. And if they're taking the world's best antihypertensive and they're not limiting salt in their diet, you're wasting your time, they're wasting their money. Okay, let's talk about aneurysms, because we've talked about the two biggest factors which are causative to aneurysms: increased pressure as well as atherosclerotic weakening of the wall. So this is a good time to talk about aneurysms. And what are some of the terms, some of the concepts with aneurysms? Aneurysms are bulging arteries. Could they be bulging from increased pressure? Could they be bulging from weakening of the wall? Could they be a true aneurysm in which the lumen is dilated, or a false aneurysm where the lumen is about normal size, but the wall is actually thicker, perhaps as focally? We know that most aneurysms are atherosclerotic. I don't know the percentage, but I'm thinking probably over 90. We know that the majority of the rest of them are congenital, and congenital non-atherosclerotic aneurysms of the brain frequently inherit the word Berry, B-E-R-R-Y, in front of them. We know that syphilis in the tertiary stage can attack and cause an aortitis and inflammation of other large blood vessels, but primarily the thoracic aorta. So you can have a luetic or syphilitic aneurysm. We know that a trauma to an artery will eventually, or could eventually, weaken its wall and therefore make it bulge due to even normal pressures. Often the term mycotic aneurysm is used, which is a misnomer, because this would lead you to believe that the aneurysm is caused by a fungus. There are a couple of fungi which basically can weaken the wall of an artery and cause an aneurysm, but for the most part, most mycotic aneurysms are non-fungal. They're probably bacterial. But the word mycotic, no matter what you use it as, implies an infectious etiology. And of course, we went, or will go through the whole family of vasculitides, and when you have a weakened wall secondary to infiltration of inflammatory cells, that can lead to an aneurysm as well. These are all logical concepts, I hope. We said that a aneurysm, if it's a perfectly round thing that looks like a berry you can pick off a tree, that's why it's called a berry aneurysm. Very often, the more barrier or the more saccular it is, the more likely it is to be congenital. Very often, the atherosclerotic aneurysms are often called berries as well. And in contrast, an aneurysm which shows a sort of gradual widening could be correctly called fusiform. And then we can talk about an aneurysm in which there is bleeding, acute active bleeding in the wall of that aneurysm, which is called dissection, versus the absence of acute dissecting hemorrhage, which is called non-dissection. Interesting thing here is that, you know, if you worked in a medical examiner's office and a young woman dies suddenly, boom, like within seconds, she's walking down the street and she dies suddenly. You know, nice woman, no drug, no diseases, no drug addictions. You take her to the coroner's office and he says, let's find the berry, because statistically that's the most likely cause of somebody, of a woman, especially in your age group, that dies suddenly with no antecedent disease. Here's a true aneurysm in which you have bulging of the lumen. Here's a normal blood vessel. You can have bulging of the artery here, but it's primarily not due to bulging of the lumen. It's due to dissection of hemorrhage within the wall. So these are called false aneurysms. Okay, microscopically, if you think of this nice elastic stain here, showing these squiggly elastic fibers within the wall, and you know this has to be an aorta because the elastic is throughout the entire wall. If it was a regular artery, it might only be, you know, the internal elastic lamina. If you think of those little squiggly things as being rubber bands, well, if you disrupt and fragment those little squiggly rubber bands due to atherosclerosis or perhaps arteritis, aortitis, that could result in an aneurysm. So it's not very likely that you'll ever see an aneurysm in which these nice little squiggly elastic fibers are sort of lamellated like you see here. When you find an aneurysm of the aorta, most of them are going to be in the abdominal aorta. And almost always the abdominal aortic aneurysms are between the level of the renal arteries and the bifurcation of the iliacs. You almost never see them above the renal. And when you see them in the, and these are all atherosclerotic, or almost all, when you see them in the thoracic aorta, a couple of generations ago, maybe more, you would, the general rule was aneurysm in the thoracic aorta, syphilis. Aneurysm in the abdominal aorta, atherosclerosis. I'm not too much, I don't really know if that's really true anymore, because syphilis has really, you know, gone down quite a bit, especially tertiary syphilis. So I would think that probably most of the aneurysms of the thoracic aorta are also atherosclerotic. Well, do I really have to show you this? You know, if that wall is weakened and bulged, you know it can rupture. You know that with enough blood clot forming along its non-uniform wall and dissecting through the wall, you get an obstruction of that artery. You know that embolism can form, and of course that embolism will travel away from the heart rather than a venous embolism which goes towards the heart. And also that embolism may be very, very likely to have little flecks of calcium on it because of part of the atherosclerotic plaque, whereas a venous embolism will probably not have calcium on it or cholesterol crystals. You know, as a mass, not only does it compress things like a ureter, a spine, urinary obstruction, but It's a pulsatile mass. So the one thing that you'll do on every abdominal examination, whether the person's fat or thin, is to just press in there. And if you feel a mass and it's really significantly pulsating, and it's probably at the level of the umbilicus approximately, you can assume it's an abdominal aortic aneurysm with a mass effect. Okay, we're still rolling. We're making good time. Here's dissection of an aneurysm. See these nice squiggly sort of lamellar or lamellated elastic fibers? Now they're being disrupted by what you absolutely know is acute hemorrhage. This is dissection. It's occurring within the wall of this aorta. And look, there's elastic fibers below it, and there's elastic fibers above it. And I'm thinking this is probably the endothelial surface here. So we got something that's dissecting right through the middle of the wall and further weakening it. What might the symptom be of an aneurysm? I hope this is all logical too. Well, it's big, bulgy, it's pulsatile, might have a mass effect. It'll encroach on surrounding structures no matter where it is. If it's in the thorax, patient can actually have respiratory difficulties because of encroachment and pulmonary airways and vessels. Kind of an interesting thing, which you may remember when you dissected your recurrent laryngeal nerve, you remember how it comes in very, very close proximity and wraps around that arch of the aorta? Well, a damage to that nerve can happen because of an aneurysm. So somebody presents with hoarseness, okay, one of the things you should always consider is an aneurysm of the thoracic aorta. It's not going to be high on the list. Dysphagia, if it presses on the esophagus. Cough, if it presses on the lung or even larger bronchial structures. Pain, because of its expansile effect. Aortic valve dilatation, if it's pressing on, if it's involving some obstruction to aortic outflow. And of course, the greatest feared sequelae, especially the large aorta, especially the thoracic, is rupture. A ruptured thoracic aneurysm is generally fatal. Okay. It wouldn't be fair if we didn't say a word about the syphilitic aneurysms. Luetic, they're also called. They're chiefly thoracic, and they're chiefly secondary to an inflammation of the aorta. You know, tertiary syphilis and even secondary syphilis produces a pattern of inflammation everywhere. You know, 3 generations ago, syphilis was called the great masquerader. Now, I think you could probably call either AIDS or atherosclerosis the great masquerader, only because syphilis is relatively rare now. But when you see a inflammatory infiltrate, and it's predominantly plasma cells, you should always put syphilis in your mind as one of the possibilities. And a thoracic aortic aneurysm, in which there's a predominance of plasma cells infiltrating that aorta, very, very good chance it's syphilis. Okay, it's generally a little bit earlier than I would start the break, but we're making pretty good time, and we got a nice big topic to talk about after the break. It's going to be the vasculitides, the general list of common inflammatory diseases of arteries. And remember, even though this is called vasculitides, they are all generally arteritides. Okay, we're still not giving fair time to the veins. We'll give a little bit of time at the end. And I'm just going to show you the list here, because these are the things we'll be talking about after the break. And we're done with this. We're going to really be in the home stretch. Whether we get to the lab or not is another story. So I'm going to pop this down, back, and we will now tackle the big topic of vasculitides, primary arterial inflammations. Probably the most popular and common of all of them, something called classically temporal arteritis, because it occurred in an artery which is not only very often visible and palpable, but even very easy to biopsy because of its collateral circulation, the superficial temporal artery. That's probably the mother of all vasculitides, and like the rest of them, they're pretty much all autoimmune, or at least may show antibodies directed against the patient's own tissues. Takayasu, also a granulomatous arterial inflammation in a specific age group. We already mentioned several times and saw in lab the so-called poly or periarteritis nodosa. They both mean the same thing, and they were always mentioned as one of the classical systemic autoimmune diseases. Kawasaki disease is not a disease you get from speeding on a motorcycle. It's a inflammatory arterial condition, chiefly involving kids. Wegener's granulomatosis, even though it's a granulomatous disease, the granulomatous inflammation, like in temporal and Takayasu, is in the artery itself. Buerger's disease 100% caused or alleviated by cigarette smoking, as well as a couple of others. I'll almost talk about a couple of bugs that love to inflame the arteries. So what are the general comments about vasculitides in general? They're almost all arterial. They're almost all non-infectious, and which means they're autoimmune. Now, the ones in which we can identify specific external antigens we call infectious, and even those infection ones are often termed mycotic. Most of them are not from fungi, most of them are from bacteria. And in a bunch of them, I'm going to lump these together, but when I go through some of them, you're going to see what is what. For example, in a lot of the vasculitides in general, you'll find the things that you usually find with autoimmune diseases, like immune complexes accumulating, or antibodies directed against the patient's own neutrophils. Okay, the ANCA antibody. That's seen with Wegener's as well as temporal arteritis, often. Anti-endothelial cell antibodies in Kawasaki disease. Well, that would pretty much explain why the artery is inflamed. The patient's making antibodies against their own endothelial cells. Now, in the smaller blood vessels, and I mean smaller arteries and even near capillary structures, very often you can see that this is related to a lot of drugs. So the so-called hypersensitivity vasculitides you cannot exclude, even though you're not likely to see them involving, large arteries. What about temporal arteritis? Now more appropriately called giant cell arteritis, because it's a granulomatous condition, and it was very, very often seen in the temporal arteries. It's not limited to the temporal artery. The reason why people thought it might have been is because the temporal artery is the only artery you can actually often see and palpate, and even very, very easily biopsy as well. So when you see a bulge in a patient's temporal artery and they might be having headaches or visual problems, very often those things go to biopsy and they send them to us. And if we easily find granulomas, then we say, bingo, you got the right diagnosis. It's usually in adults, usually older people, and even though you might actually be able to see it before you biopsy it because it's a bulge in the temple, the superficial temporal artery, very often it involves the ophthalmic arteries and some of the deeper intracranial arteries as well. So blindness is one of the most feared sequelae, and histologically it's a granulomatous inflammation, very, very, very often rich in giant cells. Now, can you diagnose giant cell arteritis? Without giant cells, if you see nice granulomas in the temporal artery of an old person that also has visual problems, of course you can. Now, there's a syndrome in which you have temporal arteritis, but it's also associated with a very, very high elevation of the patient's erythrocyte sedimentation rate. And when you have a person with temporal arteritis and a high ESR, that's called polymyalgia rheumatica. We know it's autoimmune. One of the proofs is that these patients very, very often have antibodies directed against their own neutrophils. So, here's an artery. You could see the muscle. You see some inflammatory changes in the adventitia, but you can also see inflammatory changes in the muscle. You can also see some inflammatory cells in the intima. When you look closer at some of this rather localized inflammatory infiltrate, you see multinucleated giant cells. Absolutely GCA, granulomatous arteritis, or giant cell arteritis. Here is a nice stain of an internally elastic lamina, this nice squiggly thing. I assume it's a temporal artery. It doesn't have to be. Most of them are. And you can see disruption. And if you were to zoom in on higher power, you'd see giant cells. That's probably one there. Here's a person that had temporal arteritis diagnosed by sight. It's the superficial temporal artery. There's an eye. You can see a little bulging in it, and that's the area they're likely to biopsy, and more likely than not, they'll find granulomas and giant cells. Now, could there be that same process going on in some of the deeper arteries you don't see, like the ophthalmic artery? Absolutely. Let's look at another picture. This is right from our lab case, by the way, which we're going to see maybe today or next class. You can see an arterial wall. You can see a heavy inflammatory infiltrate, and boom, 1, 2, 3, 4, 5. There's about a dozen giant cells in here too. You see, this one is probably good enough where you could actually appreciate multinucleation. In fact, I'm going to ask you, can you see the multiple nuclei inside that cell as easily as I can? That's the question. Or here, maybe this one is even better. Can you see multiple nuclei there? Good. That means that, you know, if I can barely see it and you can see it, that means that we're getting very, very good replication on this webinar. Another granulomatous arteritis is called Takayasu. You'll probably never see it. I never saw it. It loves arteries which are heavily elasticized. Remember, in the aorta, the whole wall is elastic fibers. In the main thoracic branches of the aorta, common carotid, subclavian, okay, you also have a lot of elastic tissue, not just one single internal elastic lamina. Well, Takayasu loves those big, big arteries. It's usually in young Asian women. And it's also called pulseless disease by classical nomenclature, simply because when you lose the elasticity because of granulomatous inflammation, that artery is not likely to respond with pulsatile fluctuations between systolic and diastolic pressure. So it's all called pulseless disease. And if you look at it histologically, I don't know if we're going to see it histologically. Oh yeah, we are. And you see giant cells. You might say, oh, well, this is giant cell arteritis. Well, it is because it's a granulomatous inflammation, but giant cell arteritis is generally reserved to the other disease of temporal and intracranial arteries in older adults. This is a disease of young women. Here's an aortic arch. You can see some disruptions in arterial blood flow, especially here at this area. You say, my God, what's going on in the wall of that, what is it, subclavian? That looks like there is, or maybe that's a nominate, let's say. Here is a thickened artery wall. And when you look at it, I'm sure if you saw the other giant cells well, you can see that these are really, really nice multinucleated giant cells. So, Takayasu, temporal artery, they're both giant cell granulomatous things, different population of patients. We've talked about PAN, or poly or periarteritis nodosa. Both of the terms are appropriate because it's often in multiple arteries, and very often the chief brunt of the inflammation is in the adventitia or periarteritis. So they're both appropriate. And because it could be a focal process, the artery can have a normal caliber, normal histology, and just have a segmental or a nodular area of inflammation. I think nodosa is also an appropriate term. It could occur technically in any medium or small artery, very often deep arteries in the viscera. Like any arteritis, it could cause an infarct if it's occluded. It could rupture preceded by an aneurysm, or it could rupture even if there's not an aneurysm because of weakening of the wall. It could result in ischemia on whichever area it feeds. It is one of the classical systemic autoimmune diseases. Okay, if you look at it microscopically, and we will, we're going to see an example of what I tried to tell you about before, the fibrinoid necrosis. We're going to see it's very often segmental, hence the name nodular. And you can see necrosis of the wall. And that type of necrosis is generally a little bit redder and a little bit more granular than regular old collagen. So, and it looks like fibrin because fibrin is usually granular on H&E. So that's why it's called fibrinoid. It's not fibrin, but it looks like fibrin. And very often you'll find anti-neutrophil antibodies here too, especially in the smaller vessels that are involved. And remember, when we gave the big dissertation on the systemic autoimmune diseases, PAN was on the list. But remember, in addition to that, any systemic autoimmune disease, whether it's lupus or rheumatoid or even scleroderma, systemic sclerosis, it can also have an arteritis as part of it as well. So if you are asking me, well, if I see an inflamed artery, how do I know whether it's PAN versus one of the arteritity components of these other systemic autoimmune diseases? And of course the answer is, on histology alone, you can't. Here's a artery. You could see the brunt of the inflammation is around it in the adventitia or peri, but you can see it also involves the entire wall, especially here. Here the media is involved. Here there's a lot of intimal involvement. So it's really a panarteritis, but the majority of it usually is peri. And it's often more than one artery that's involved, so that's why it's also called poly. And I don't think I'll live long enough to where somebody makes a law where you got to call it one or the other. It's very often called both. Classical autoimmune disease. Now, if you say, well, if I told you this patient had rheumatoid arthritis and this was a little mesenteric vessel like we're going to see in the lab, you say, how do you know this is not part of rheumatoid or lupus even? And I'll say, well, I don't know, it's just an arteritis. There's nothing specifically about it. Another thing to remember is here, take a look at the character. Oh, here, let me see if I could do this. Take a look at the character of the eosinophilic granular substance. Is it a little bit more granular than what we usually just see in regular fibrosis? Does it look like fibrin, especially here? Okay? That's why it's called fibrinoid. So technically, fibrinoid necrosis is usually a term referred to in arteries, and most often they're arteries of arteritis. Here's Kawasaki disease. My wife thought I was going to die of Kawasaki disease because I drove a 750 turbo for about 20 years. It had the greatest acceleration of any motorcycle I've ever had. I took her on it once and she never went on it again. But Kawasaki disease is also an arterial disease. It's usually in kids. It's the leading cause of acquired heart disease in kids. As you might guess, it's popular in Japan. That's why it got Kawasaki. We also get it in the United States. And generally speaking, has a low fatality, but some of the kids, only 1%, might die of a heart attack due to coronary artery Kawasaki disease. There's also talk about other symptoms that you'll sometimes see, like a red tongue and cervical adenopathy, but those aren't always present. And to show you that it's autoimmune, we have anti-endothelial antibodies. To me, the reason why these arteries here, they might be coronary arteries, are inflamed is because we have antibodies directed directly against the endothelial cells. So would you think, if that was the case, that perhaps the brunt of the inflammation might be intimal, like you see here, maybe with a relatively small amount of adventitia involvement? Well, that would be a good theory to correlate the anti-endothelial antibodies with the actual histopathology. This disease goes by a wide variety of names. It's all the same thing, but it is a vasculitis. It's usually small blood vessels, even capillaries and veins, but also arterioles. It's usually the very small ones that are microscopic. It's frequently in the skin, so it's basically a dermatologist disease. And I'll give you the three names. One of them is microscopic polyangiitis. One of them is hypersensitivity vasculitis. And the most preferred term, we had a dermatopathologist talk about inflammatory skin diseases. The pathologists and dermatopathologists and dermatologists, they usually use the preferred term leukocytoclastic vasculitis. And the reason why it's called leukocytoclastic is because you know what a leukocyte is, right? And you know what clastic means, don't you? It means fragmentation. So in this disease, with the inflammatory changes in the small vessels, you also have fragmentation of the leukocytes, or neutrophils. And that's the term called nuclear dust. It's also called leukocytoclasia. And very often, more often than not, most of these are allergic reactions, and they're sometimes caused by penicillin, or even strep can be a factor as well. And probably because if they involve the superficial vessels of the skin, this is basically a dermatologist disease. Here's a nice picture. Now I want to point something out. This epidermis is out of focus. You can see a stratum corneum here, but you could generally imagine that the entire epidermis looks pretty normal. What you can see, however, is a bunch of inflammation in the dermis, and you can see a good sized blood vessel here. There's some inflammatory cells in its wall. I think the inflammation of a small vessel is better demonstrated here. And do you see, if let's say this and this and this is a normal size of a nucleus of any cell, what about these tiny things like there and there and there, which look much smaller, but they have the same staining property as a nucleus? Well, they're fragments of nuclei, and they're fragments of neutrophil nuclei. That's called nuclear dust. That's the leukocytoclasia. Okay, we're down near the end. We'll talk about Wegener's granulomatosis, still very, very much a mysterious disease. It's very often more often in females than in men. It's in middle age, so we'll say 40s. It's very often necrotizing granulomas. Two features of Wegener's granulomatosis is, number one, granulomas, and they're all necrotizing. They're necrotic. And they're almost always limited to the upper and lower respiratory tract, sometimes the kidney. And it starts out in the blood vessels. And even though it may start out in the small blood vessels, very often the granulomatous reaction is large. It might be several centimeters in diameter. It might look like lung cancer. Okay? It used to have a pretty high mortality. With high immunosuppressive therapy, that mortality is massively improved in the last couple generations. Very often when it has renal involvement, you can see a crescentic glomerulonephritis. And for those of you who were here for the renal lecture, you remember crescentic usually implies clinically a rapidly progressive glomerulonephritis, because you actually see little crescents in the glomeruli. And almost always, once again, it's autoimmune. You see anti-neutrophil cytoplasmic antibodies, or what they call ANCAs. So here is a lung and it has some infiltrate. This could be anything. Up here, the infiltrates on CT look pretty big. Up here on the actual autopsy specimen, you can see not only necrosis, but liquefaction and hemorrhage within the center of the large granulomas. You might think this is lung cancer, clinically, radiologically, even grossly, but it's just big, huge necrotic granulomas. Remember, they also involve the upper respiratory tract, the nose, the pharynx. If these two little dots here look similar, that's totally a coincidence. These are actual neutrophils. You can see the three lobes in here. They're just blown up neutrophils. And the reason why they glow is because they were labeled with a fluorescent antibody against neutrophilic cytoplasmic antibodies. So these neutrophils are C-ANCA positive. They show that this patient had antibodies against the cytoplasm of neutrophils. And that's why they look like that. Now, if you think this picture here looks similar, it's absolutely not. This is an eye. This is a keratitis and an iritis, okay? This is something that you often see with the disease also. That's why there's an irregularity of the iris, an opacification of the cornea. You may see this in the disease too. But the thing that I want to emphasize the most is that when you look at these granulomas, they're vastly, largely, and even entirely necrotic. So it's not unusual to have a granuloma of this size and you make, 20 sections through it, and it's all necrotic crud. You're looking for, one or two types of cells to identify, just all necrotic crud. Now, I know what you're thinking. You're thinking, well, if these granulomas are necrotic and they have that crumbly appearance like cheese, why aren't they called caseating granulomas? Well, the reason is, I think it's by convention. Usually when you use the word caseation, even though it means crumbly necrosis like cheese, for some reason that term has been sort of the property of tuberculosis. So I don't think anybody would ever call the necrotic textures, crumbly necrotic cheesy textures of Wegener's caseation necrosis. I know you can, but people usually don't. Okay, here's another one. It's called Buerger's disease. It's also called thromboangiitis. So as you might guess, the vessel may be thrombotic and inflamed, the angiitis, and you may also guess that it could be so significantly inflamed that it actually obliterates the lumen. And that's why it's called thromboangiitis obliterans, but everybody calls it Buerger's disease. And the one thing we know about it is that we all know that cigarette smoke has a horrible effect on blood vessels in general, major risk factor for atherosclerosis. But for some reason, it has a really quick, devastating effect on people that have Buerger's disease. It's almost always in men. They're not really very old. They're all big smokers. And they all may have gangrenous extremities because their large arteries are obliterated by an inflammatory response. So when you see a 30-year-old cigarette smoker and he doesn't really have any major risk factors and he has necrotic toes, think Buerger's disease. And look, if I was to tell you this was an artery here, you'd probably say, you're full of baloney. It can't be an artery. There's no lumen. Well, guess what? The lumen is obliterated. And do you see how it's different from atherosclerosis? In atherosclerosis, you might see lipid, plaque, calcium perhaps, cholesterol, clefts. Up here, it's just all inflammatory infiltrate. Not granulomatous. It looks like organizing inflammation. It's actually obliterating the lumen here, or almost obliterating it here, and well on the way over here. Okay. Don't think that arteridities are really different from the systemic autoimmune diseases, because every systemic autoimmune disease usually has an arteritis as part of its expression. And we're going to see a couple cases from the lab in which you have a classical arteritis, but it's in the gut or the adrenal perhaps, and it's somebody with rheumatoid arthritis. So don't ever think rheumatoid arthritis is strictly joints. You know, you have rheumatoid nodules in the skin and the lung, and very often a vascular component. Also with lupus too. Lupus is very big for producing. So don't make the mistake of thinking arteritis are different from classical systemic autoimmune diseases. Now, we said that 95% of the arteritis are non-infectious and therefore probably autoimmune. But let's talk about a couple of bugs. Aspergillus fungus, the septate fungus, okay? Very, very often. I actually did an autopsy once on a guy that had Aspergillus endocarditis. If you remember, we talked about mucormycosis, also a hyphal fungus with septae that can occur in patients that are very, very much immunosuppressed, including severe diabetics. These are two things. And the thing is, these are both fungi, aren't they? So in that case, the word mycotic aneurysm would actually be appropriate because these are fungi. Myco means fungus. But most of the things called mycotic aneurysms are not fungi, and generally speaking, more likely to be involved by a wide variety of bacteria. Okay. Got a couple of small things to finish up on. I don't know if we'll get to lab. I doubt it. We've neglected entirely the primary diseases of veins. We've so far devoted all of our time to talking about arteries. We also, like in almost every other chapter of Robbins, at the end have to consider neoplasms, the common benign and malignant neoplasms of blood vessels too. So those are our final topics. But the first thing I want to discuss is Raynaud's phenomenon. And you notice it says Raynaud. More often than not, it might be called Raynaud's. It's a phenomenon, okay? It's not a disease. It's a phenomenon. It means very often there are really no demonstrated pathologic findings. So if you don't have a demonstrated pathologic finding, you don't have a disease. It's more of a spasm of an artery, physiologic, due to a wide variety of things, rather than a specific disease. It's more of a clinical symptom than a disease. We'll talk about veins and lymphatics after that, and finally tumors, and a couple words on intervention. So let's start out with the Raynaud phenomenon. It's very common. Women are much, much more common in women than men. You can consider it a primary disease. It was formerly called Raynaud disease, but now it's more likely to be called primary Raynaud phenomenon. And it's a situation in which generally healthy looking arteries constrict, usually triggered off by the cold and sometimes emotion. And it's usually in the digits, it's usually in the hands, but it could also be in the toes. It could also be the tip of the nose. And it's a generally temporary physiologic vasoconstriction of normal arteries. And if it was not temporary, you might expect gangrenous changes to occur in the fingers, and usually they don't, okay? When you examine the arteries, they don't show any pathology. That's why it's called phenomenon rather than disease. But the thing that they do show clinically and reliably are color changes. And it's not just good enough to remember red, white, and blue, okay? You have to remember the order in which these colors occur. When an artery constricts, there's pallor in that extremity or nose or digit, and they're white. Okay, now later on, maybe minutes even, because there are some cyanotic changes, they are then blue. Finally, as sort of a reactive hyperemia, they are red. So the correct order of this is white, blue, red. Now, this exact same condition, not associated with anything occurring idiopathically, called Raynaud's phenomenon, can also occur secondarily to other well-known diseases like atherosclerosis, the arteritis of lupus, Berger's disease, remember? But in this case, you actually see pathologic changes. So Raynaud's phenomenon in normal arteries is called Raynaud's disease, or primary. Raynaud's phenomenon in arteries with known, whoops, I misspelled that, in known arterial diseases is called secondary, and those changes are demonstrated pathologically. Here's a more reliable thing. It's very, very easy. You look at the hands. This patient's been exposed to cold, most likely. That looks blue to me. That looks white to me. And that looks red to me. So the things that are red probably were previously looking a little bit blue, and the things that were blue probably previously looking red. And by the way, I found something you'll never see in your life, but it's a real spectacular picture. And I don't know if there was some enhancement of light going on here. The thing you'll notice in Raynaud's is very often there's a very, very distinct difference, between the colored areas. And I don't think you'll ever see this in your life. I never have, except for this Googled picture. But if you ever see something like that, it should be a knee-jerk diagnosis. I have a very good friend that I wanted to take this weekend to view some eagles along the Mississippi River, and it's probably going to be cold, and she said, I can't go, I have Raynaud's phenomenon. And I thought, oh shit. Okay, let's talk about veins. We've been neglecting them. Maybe there's not a hell of a lot to say about them. The most common disease of veins, varicose veins. And if varicose sounds familiar, like when we talked about varices of the stomach or esophagus with cirrhosis, or tortuous dilated blood vessels in rectal blood vessels called hemorrhoids, they're all basically the same thing. About 20% of women have varicose veins. The usual primary cause is leg vein incompetence of the valves. Okay, so when you have the veins, especially the large veins in your legs, superficial veins, they have valves. When there's some valvular problem, they generally tend to pool. When they pool, they become dilated. When they become dilated, they can become a little bit more tortuous. Under the increased pressure, the veins may become thickened as well. So these are all the features of varicose veins. If you'd rather call them varices, you can, but once you say varice, you're probably referring to somebody with cirrhosis, and varicosities are what we call them in this situation. The veins are dilated, they're tortuous, they're elongated. Under the increased pressure, the wall becomes thickened and sclerotic, often can find calcifications, and the usually normal, thin, smooth muscle could be disrupted because of the scarring. And conceptually, they're probably the same sort of thing as the varices or hemorrhoids that you see in other locations when there's portal hypertension or increased abdominal pressure. The diagnosis you'll get back from your pathologist is not varicosity, because that's a clinical term. Usually on the pathology report, if these patients have surgery, which fewer and fewer of them do have nowadays, they're usually treated through sclerotherapy. But most of these things come back as a phlebosclerosis on the pathology report, meaning the veins have some thickening and fibrosis of the wall. That's what we called them anyway. In fact, it was almost a knee-jerk reflex. Nobody ever got excited over varicose veins as specimens, so we would just, throw them in the bucket have some slides made, look at them, and 2 seconds later, whether we looked at it or not, just call it phlebosclerosis. Here's some spectacular examples. Dilated, superficial, tortuous veins with increased pressure, probably some sclerosis of the wall. I don't know why this is terribly blue, if there was some diagnostic technique used here or whether there was some hemorrhage. I would try to ignore that part because I can't see how it would only be affecting one leg and not the other. I think there's some trick going on over here. Thrombophlebitis. Okay, very often not really regarded as a primary vein disorder itself, even though it's inflammation of the vein wall. It's usually much more likely related to a thrombus that's inside the vein. Nevertheless, when you get a diagnosis of thrombophlebitis, most likely the area of concern are the deep veins of the leg. Now, thrombophlebitis technically is inflammation of a vein with a thrombus anywhere, okay? But the part that is of most clinical concern, when you have a diagnosis of thrombophlebitis, in part of your hospital's coding system, it's probably going to be related to deep vein. Superficial veins of the legs do not give rise to pulmonary embolism. Superficial veins anywhere else do not give rise to pulmonary embolism. It's only the deep veins of the pelvis and lower extremities that give rise to PE. So the factors of thrombophlebitis are the same as basically the factors of thrombosis anywhere. Stasis of blood flow, like in CHF. Many of the malignancies, especially the GI malignancies, it was first described in pancreas, but also colon, also lung, have a migratory type of thrombophlebitis. And pregnancy can produce a thrombophlebitis because of pressure on the large veins and stasis of flow. It's related to obesity. The number one concern of any surgery, general anesthesia, is a pulmonary embolism follow. So they make sure that those legs are nicely taped up during the surgery. And technically, immobilization of lower extremities due to any reason, and probably the most common reason is significant chronic illness, is a significant risk factor for thrombophlebitis. But if you remember in Virchow's triangle, any of the factors in Virchow's triangle which tend to accelerate a thrombotic process would be a factor in thrombophlebitis. The most feared sequelae, of course, of a thrombosis of a deep vein of the leg or deep vein of the pelvis is a pulmonary embolism. We'll be dealing with that separately. Probably not inappropriate now to say that if a vein in a large extremity deep is thrombosed, you can have edema of that leg just because of impaired venous return. You're going to have cyanosis, perhaps. It's a little more severe because of inability to perfuse oxygenated blood. Any inflammatory process will produce heat, pain, swelling. These are just all the classical signs of inflammation. No big surprise here. However, most people that are admitted to hospital with thrombophlebitis, you could do a lot of things like, measure the diameter very carefully and all that. Really, most of them will not have any of these symptoms. So just like with a pulmonary embolism, the majority of people with pulmonary embolism are asymptomatic. The majority of people with thrombophlebitis or the deep veins are also asymptomatic. Here's something significant in the superior vena cava. We can't ignore that large vein. Something that compresses the superior vena cava, usually externally, can cause the SVC syndrome, in which you have impaired drainage from the superior vena cava, edema of the head, neck, and arms. Okay, this is all the drainage area. Also a cyanosis because of a decrease of oxygenated blood. This is the same person before and after the correction of the SBC syndrome? Could it have been removal of the thoracic tumor, perhaps? So you could see that this woman is normal. This woman has what's classically called dusky cyanosis of the region of the distribution of the superior vena cava, the head, the neck, and the arms. Let's take the other big vein, the inferior vena cava, and just like with the superior vena cava, most likely a reason for it would be external compression such as neoplasms. But if you have a large thrombosis, in the pelvis and involving the iliacs, that can extend into the inferior vena cava. You could have a large abdominal aortic aneurysm pressing on it, causing either, number one, impaired flow or stasis of flow and therefore thrombosis. And of course, in IVC syndrome, you have bilateral leg edema. Just like in SVC syndrome, you have bilateral arm edema. The thing to remember is that we're also talking about the renal veins here, too. So anything that shows a significant obstruction of the renal veins, it's probably going to result in massive proteinuria. Okay, so think renal vein thrombosis, whether it's a regular clot or a tumor or a compression, massive proteinuria. Not exactly the same as the nephrotic syndrome, because there are the other things in nephrotic syndrome, but massive proteinuria in IVC syndrome. The one thing we've totally neglected are the lymphatics. A lymphangitis is technically an inflammation of the lymphatic vessels. The most common causes of bacteria, group A beta hemolytic strep, most likely. In a theoretical lymphangitis, you have your lymphatics filled with, maybe even dilated with white blood cells. It's almost always associated with a cellulitis as well, so not only are the lymphatics dilated, but there's edema, and the white cells extend into the soft tissues as well, which is called cellulitis. And of course, the general principle is if your lymph node, which is receiving those cells, cannot process that infection, then most likely that bacteria, group A beta hemolytic strep, will then go out and cause a septicemia. So the common childhood fear, their mother told them that if the infection travels up to their arm, they'll get blood poison and die. Well, that sounds pretty crazy, but the pathophysiologic principle is right there. If the lymph node can't clear the infection, bacteria are very likely to go into the blood. Here's a lymphangitis. I got one in which there's very little cellulitis. There's not much swelling in this soft tissue. I think you could tell that. We could say, well, maybe is there some swelling in the toe there? I don't know, maybe, or maybe they're just bumpy toes. You can see the redness. You don't see much swelling. Could it be a little bit warm? Yeah, because it's acute inflammation. If you see, and you usually do, a large amount of cellulitis with this, you'd probably not be likely to diagnose a cellulitis. A lymphangitis. You'd probably be more likely to call it cellulitis. So is it a spectrum? Sure. Any significant lymphangitis will result in a cellulitis, and if the predominant clinical anatomic sign or symptom is a cellulitis, you call it cellulitis. Lymphedema, we've said this before in our hemodynamic thing. Anything that damages lymphatics, whether it's surgery, whether it's radiation, whether it's a tumor, whether it's parasites hiding out in the little lymphatics, blocking them, will result in lymphedema. So lymphedema in this woman here, and in most cases of lymphedema, especially in the older days when more drastic surgery was done for breast, was the result of damaged lymphatics due to surgery. It was just, one of the obvious things you could not avoid. Here's a normal arm, here's a lymphedema arm. Here is a very massive lymphedema, and it looks like it's a man. I'm not sure. It's in the lower extremity, but it doesn't matter. But massive, massive lower extremity lymphedema is not usually seen in this country. It's usually seen in countries where the filarial, the tiny worm parasites, are involving the lymphatics of the groin and the inguinal area, and as a result, all of the fluid from the lower extremities can't be filtered through the lymphatics, so the lymphatics are blocked by the fact that they have little worm parasites living in them. So for those of you who have ever gone to a bookstore and paged through a pathology book, probably the single most horrible thing that you'll see, you always look for the page of the lymphedema, and you find some guy in Africa whose scrotum is all the way down to his ankles practically, and you know that that's lymphedema. Lymphedema could be congenital as well, based on failure of proper development of the lymphatic vessels. I've never seen one, it's rare, but it happens. Now, there's a certain type of skin lymphedema that you're likely to see, and it's called peau d'orange. And for those of you who don't know French, like me, it means orange peel. And it usually occurs in carcinomas, especially breast carcinomas, in which the little lymphatic blood vessels are blocked by small nests of tumor cells. Now, if I showed you this picture right here, and you would say, well, why would Dr. Minarsik be showing us a picture of an orange in a pathology class? Well, this is not an orange. This is skin in a breast in which there was massive lymphatic involvement by the dermal lymphatics by these little tumor cells within small lymphatic vessels. Do you see? There is an endothelial cell there. There is an endothelial cell there. And look, there's absolutely no muscle around it. That's a lymphatic vessel. These are tumor cells. They're big and dark. They look like breast, but trust me, they're tumor cells. And if they block up enough lymphatics, it makes the superficial dermis very, very puffy looking. And look, you see these little pores over there? Those are the openings to the eccrine sweat glands. And the reason they were so prominent is because the skin or the dermis around them is so swollen, it makes those little openings of the sweat glands look more prominent. Obstruction of lymphatics at the level of the thoracic duct might produce a significant amount of lymphatic fluid, white, milky lymph or lymphatic fluid within the thorax. Okay? Or, most likely, if it's blocked at the level of the diaphragm or higher even, it might produce chyle or lymph fluid. Chyle is the same as lymph fluid, C-H-Y-L-E, in the abdomen, and that's called chylosocites. And if it involves the thorax, it's called chylothorax. It could even involve the pericardium. I've never seen it. Chylopericardium. Okay, now you're thinking, why isn't this consistent? If you call this hydrothorax and hydropericardium and hydroperitoneum, well, you just call this chyloperitoneum. Well, I guess technically you could to be consistent, but nobody calls it that. They all call it chylous ascites. Okay, we're down to our last topic, almost, of tumors. And that's always the topic that comes at the end of almost every chapter. There's a little bit on this, and then we're talking about stents, but rather than trying to rush through this, we're going to end here. And we're going to end here because there's also about a dozen cases from lab, and there's no way I could fit this in, and I don't want to feel like I'm a slave to a schedule. So in the next session, we'll finish off on vascular tumors, say a couple words about stents and bypasses and grafts, and then we're going to do a lab, and then we'll have time to start the next chapter on heart. How does that sound? So we'll call it a day, except I've been neglecting you again because I haven't asked you the big question, and the big question was, did you all hear me well in the second half?